and underweight, and people being worried about their growth. And then subsequently, there will be worries about delay with their development. Some boys, particularly the boys who've got the involvement of this filamin gene in their duplication, have difficulties with the bowel and the bladder not working very well because the nervous system controlling the bowel and the bladder is not developed in quite the normal way. And then I mentioned that just like girls with Rett syndrome have some unusual movements, a lot of boys with MECP2 duplication will have some unusual movements. Not quite the same as Rett syndrome, some of the boys do a bit of hand wringing, but they will have some repetitive hand movements. In fact, I noticed on one of the recent publications on this condition that's been published, if you look in that paper at the bottom, if you go to it online and you look in that paper, in the supplementary information of that paper, they've included a video clip which you can access online to show these characteristic repetitive movements that are seen in a lot of boys with an XQ2A duplication. Many boys also have seizures of different types, and if you do an EEG test, you do see some abnormal rhythms on the EEG pattern along with seizures. And then there's also accumulating literature suggesting that boys with an XQ2A duplication fulfill some of the diagnostic criteria for autism. Because there's a lot of people wanting to research into autism, they've then focused very much on this region of the X chromosome now to try and do research on that. So this is the paper that's just been published. It's got the link to the movement disorder. And for anyone who wants to read a medical paper, this I think is a very good review of XQ2A duplications. And it was published by someone called Ramoki in 2010, and that's the reference. And they also published some photographs of some of the children that they'd reviewed. Now, some people have said that there are similarities in facial features amongst boys who have an XQ2A duplication. And there may be some similarities, but I think it's not a diagnosis that we can have on facial features. Conditions like Down syndrome make the diagnosis but I don't feel, and I'm used to diagnosis, that this is that sort of diagnosis. I think, yes, there may be some similarities, but I think they're very subtle. They look very much like their parents and what you'd expect from a family. This is a paper that's also published, and this is just to say that there is a lot of variability within this condition. So, this is some doctors from Norway who published a paper about 2 boys with XQ2A duplication. And they picked this up by chance when they were doing one of these CGH tests. Hadn't thought about the diagnosis. And the reason they hadn't thought about the diagnosis was that these 2 boys seemed to be doing too well for what they read in the textbook. And unlike some boys, most boys with this condition have a smaller head size, these boys didn't, they had a bigger head size. And also, these boys, they'd had the odd chest infection in the first year of life, but then their infections completely cleared up and they were fine after that. So they were pointing out that it is a variable condition, and the first reports in the medical literature are always the boys who have the most problems, but it reminded us as doctors looking at this condition to have a broad index of suspicion, and that boys can present in different ways, and some boys do have a milder version of the condition. So just to talk a little bit about the genetics, and again, many of you will have gone over this with your clinical geneticist, and I would encourage anyone who hasn't to discuss this and discuss your individual situation with your clinical geneticist. But we know that XQ28 duplications can run in families. So of the many families reported in the literature, and of the families we know in our clinics, we know that often there is more than one boy in that family who has an XQ28 duplication. And when you look at the structure of the families, what we can see is often that you get affected boys. I'll come on to mention girls a little bit later, but you get usually affected boys in a family, but no affected girls. And when you look at the family structure, you can see that the genetic change leading to the XQ28 duplication seems to be carried by completely healthy women, but can be transmitted to boys. So this is a feature of what we call X-linked inheritance, because the gene change is on the X chromosome. So just to talk a little bit about X-linked inheritance. So this is a diagram of a family where there's a mother over there who is fit and healthy, but on one of her X chromosomes she has an XQ28 duplication. And we have a father who doesn't have the XQ duplication, otherwise he would have the symptoms. And this is a healthy father, so we know he doesn't have the duplication. So if you get a mother who carries this and a father, if you look at the possible types of children they can have, every time they have a child, they can only pass on one of their sex chromosomes. So the mom can only pass on one of her X chromosomes, and the dad passes on either an X or a Y. So those two parents, a carrier mother and a dad, can have 4 combinations of children. So first over here, the mom passes on her normal X and the dad passes on his X, and that's a daughter who hasn't inherited the duplication, who's fit and healthy. Secondly, we get the mom passes on her normal X, the dad passes on his Y, so it's going to be a boy, but a fit and healthy boy, because that boy hasn't got the duplication. Thirdly, the mom passes on the X with the duplication, and the dad passes on his X, so that's a girl who's got 2 X's, and that girl is almost certainly going to be healthy, but is a carrier of the same duplication as her mom. And fourthly, we've got a mum who passes on the X with the duplication, and the dad passes on his boy. So that's a boy, but that boy carries the duplication, so he's going to be affected by the condition. So this is, not all mothers of affected boys are carriers of the duplication. And if a mother is a carrier, the risk overall of that couple, as I showed on the previous slide, having a boy with an XQ28 duplication is 1 in 4. However, once you know during the pregnancy that you're having a boy, that risk for having an affected boy is 1 in 2, because you know you're having a boy, and 1 in 2 boys will be affected. And if you know you're having a girl, the risk of having a carrier girl, but who will probably be fit and healthy, is also 1 in 2. And we have to remember that chance has no memory when we're talking about genetics. So if you had a boy with an XQ28 duplication in the last pregnancy, it doesn't mean that this pregnancy you'll have one of the other combinations of genes. Your risk would still be 1 in 4 for having a boy with the condition, even in the next pregnancy, because it's 1 in 4 every single pregnancy. And as I said, particularly for families who are planning more children, it's really important to discuss individual risks with your clinical geneticist, because this is the situation in general, but of course every situation is individual, and we know that in some circumstances the mother isn't a carrier of that XQ28 duplication, and it just arose for the first time in an affected child, and therefore the risks are much, much lower. And so it's important that every family finds out individually what their individual risks are. So what about girls then? We've talked about mums who are carriers who are healthy, and that girls who are carriers are usually healthy. So why are they healthy if they carry the same XQ28 duplication? Well, the reason is that girls have got 2 X chromosomes, as we discussed, But actually, you only need the genes from one X chromosome to be fit and healthy. So, in general, a girl can survive just on one X chromosome. And what happens is, when that girl embryo is tiny and developing, she has 2 X chromosomes for the first few days or so, and then one of them shrivels up into a little ball at the side of the cell and becomes inactive and is never used again. So really, she works off one X chromosome worth of genes, and that's all you need. And if you have too many X chromosome genes, then you run into the same problem as a boy who's got an XQ28 duplication. And sometimes you can get girls with an XQ28 duplication who show some symptoms. Normally you don't, because they can activate one X and only work on one X chromosome's worth of genes. But occasionally, what happens is they've got 2 X's, one with the duplication and one that's normal. And if they shrivel up the normal one and leave the one with the duplication active, they're just the same as if they're a boy with the duplication, so they get the symptoms. If you look at it, most girls who are affected, they have a little bit of a halfway house and aren't quite so severely affected as boys. And most carrier girls, particularly if you're in a family where there have been lots of affected people and healthy females, are normal and healthy. So the risks for girls are low, but they do exist. Okay? Just another thing to mention is that sometimes, instead of having a double copy of that extra piece of X chromosome, you can have 3 copies. So you can have not just a duplication, you can have a triplication. And this is an article that was in the literature of a baby who had a triplication, 3 copies of all those genes. And the more copies you have, the more severe your symptoms are. So usually if you have 3 copies, then you have a very severe picture, and many babies who would have 3 copies would not survive very long because they had a more severe picture than 2 copies. And the reason you get these extra copies on that part of the X chromosome is to do with the fact that that X chromosome, that little piece down at the end, has got a DNA sequence which is very repetitive. And it means that when it's copying itself from parent to child and into the cells, it means that it can increase spontaneously in size or decrease in size, and there's lots and lots of variation of that piece of the X chromosome. It's an inherent property of the X chromosome that it can duplicate, it can triplicate, and sometimes it can even get 4 copies. So most often it will just be 2 copies. So at MECP2 we do genetic testing for this condition, and there are lots of reasons we do genetic testing. And the first one is to confirm the diagnosis and to try and find a diagnosis for a child who's got a learning disability where often we've looked at everything else, we can't find everything, and we need to know the diagnosis so that we can manage that child. The other reasons we do genetic testing are we would offer genetic testing to females in the family to see if they were carriers, because they might want to know that if they were planning to have more children in the future, because they would base their decisions on that probably. We sometimes do genetic testing to determine if babies are affected during a pregnancy, if that was something that parents wanted. And if we do that, the options are to do a test at 11 weeks of pregnancy, or now there's the newer sorts of tests called pre-implantation genetic diagnosis, where you have like an IVF technique and you test the embryo when it's just a few cells big before you implant the embryo. So there is a shift towards pre-implantation for some families, but that's quite a difficult process technically, and for anyone thinking about prenatal tests, you really have to decide what's best for you individually. And then there is research going on into XQ28 duplication, and the aim of the research really is to learn more, first of all, about how the condition affects boys and a few girls with the condition, so that we can learn what problems they have and what we need to do to manage these children best. And then there's a lot of genetic and scientific research going on to try and see if there can be treatments developed for MECP2 duplication.